All right. Well, thank you all for joining us for this continuing education webinar. I'm Aziza Belcher-Platt, the Education and Training Representative for APA's Division 49. And on behalf of Division 49 CE Committee and all of Division 49, we want to welcome you to this webinar. It is my honor to introduce Jerry L. Jennings. So Dr. Jennings is the recently retired Vice President of Clinical Services for Liberty Healthcare Corporation, where he played a central role in the development of specialized clinical program capabilities for challenging populations, including forensic psychiatry, co-occurring SPMI and substance use, corrections, and community release. He has published over 60 journal articles, chapters, and books in clinical and forensic psychology, domestic violence, phenomenology, group therapy, and sex offense-specific treatment. Dr. Jennings co-authored the first book devoted entirely to group therapy with sexual abuses in 2016, and the first workbook for orienting and engaging clients in group-based treatment called Getting the Most from Group. Other publications include a comprehensive review of the empirical and clinical research specific to group therapy with sexual abusers, facilitating GLM groups, group therapy for psychopathy, and 2 workbooks for you titled Responsibility and Self-Management and the Mindfulness Toolkit. He has conducted numerous trainings related to forensic psychology and sexual abuse treatment. His analysis of an infamous sexual predator, based on his book, Breaking the Silence of the Lambs, is featured in the documentary Monster Preacher and A&E's I Survived a Serial Killer. Stephen Sawyer earned his MSSW from the University of Wisconsin in 1980. He is a licensed independent clinical social worker and is founder and president of Sawyer Solutions, LLC, a private clinical and consulting practice. He was a founding board member and executive director of Project Pathfinder, Inc., a founding board member and past chapter president of the Minnesota chapter of the Association for the Treatment of Sexual Abusers, and is a past board member and chair of the Minnesota Board of Social Work. In his clinical practice, he provides clinical and consultation services to individuals, families, and organizations. He currently serves as a consultant to Catholic religious orders on matters of sexual abuse prevention and management, and provides clinical supervision services for the state of Minnesota. Over the past 35 years, he has assessed and treated hundreds of men who have committed sexual crimes and has supervised the treatment of several thousand men in sexual offender treatment. Mr. Sawyer is an experienced public speaker who has given lectures and trainings locally and nationally to public and professional groups about sexual offender treatment and sexual abuse prevention. He has published more than 20 articles and book chapters on a variety of topics, including a program for men who use prostitutes, sexual abuse in the Catholic Church, group therapy with sexual offenders, sex dysfunction in sex offenders, and sex offender treatment program outcome research. So without further ado, I turn it over to Jerry and Steve.
Welcome. Welcome. Thank you. Can you hear me okay now that I signed back in? Okay. Sometimes this technology makes me sound like Alvin the Chipmunk. So I wanted to make sure that technology worked. Well, welcome. It's a pleasure to be here. I'm wondering what parts of the country are you folks that are signed in? Could you just quick in the chat, what part of the country are you in?
I think they can speak out loud and be heard.
Oh, if you're on, go ahead. Oh, Missouri, yeah. Great, okay. Yeah, I was in Missouri a couple of years ago. Louisiana, yep, excellent.
I'm from Sudbury, Ontario, Canada.
Oh, hello. Hello, yeah. I have a good friend in Toronto. Very good. Okay, thank you. It just helps us get here I am in Minnesota, Jerry's in Philadelphia. And so we've got a good chunk of the country represented. I appreciate that. Let me get the screen share going, and then we'll get that, make sure that's working. Great. Oops, okay. And we'll do the slideshow. Oh gosh, there we go. Okay. I apologize. My computer, sometimes it just ends up in a soup, doing a loop and running stuff in the background. It gets really hung up. It's hung up now again, I can tell. So thank you for the introduction, Aziza. I don't know that I want to say a whole lot more about my background. I'm a practicing clinician. I have an aftercare group where I've known most of those men for 5 to 20 years. and do a little bit of individual therapy. I'm no longer actively functioning in an outpatient treatment program, and still doing some supervision, clinical supervision. You want to say anything else about your background, Jerry?
Just the key word in Aziz's introduction was recently retired. Yeah, I'm very, very happy to be here today, but I'm enjoying my new life, not seeing people and doing this work directly.
Yeah. I might get there soon. So today's topic, we're used to training in our field with clinicians and corrections department professionals who work directly with the criminal justice system and with adolescents and adults, men and women, who have committed some kind of sexual crime. And so to venture into a different professional group, we think it's really an interesting conversation to have about how we've worked for, gosh, almost 2 decades now, talking about group work, but bringing the rich history of group therapy into our specialty. So that was the idea behind this, that we're not going to do a whole lot of training about group therapy per se, because we imagine most of you are well versed in that. But we'll bring it more deeply into our field in particular. Okay, so let's see if the advance works. Okay, so this is really about how we envision the opportunity and maybe some of the challenges about doing group work with this very unique population. The quotes I have here, so I was in the same, ran the same treatment group for 20 years, outpatient treatment, and saw lots of evolution of that group, developmental stages, degrees of cohesion or less cohesion. But there's so much wisdom in those groups. And so this first quote was a man who had been in the group a couple of years and I think was about to leave. But he made this observation about the group as like an organism. He watched it change and adapt over the years. He was there because it was an open group. So there were men coming and going and finishing treatment and starting new. But he recognized that when a group member leaves, it affects the group. And that little tidbit is so true in every group I've been in. Even if someone leaves, sometimes there's adverse discharges. And even with an adverse discharge, it affects the group. And so the appreciation of how does a new member get brought into a group, welcome to a group, oriented, how they participate, and then what we do as someone leaves a group, all of that affects the group. So thinking about what are the experiences our clients have in those groups is really critical for how I've been trying to learn how to facilitate groups. And an anonymous quote, I'm not sure where that one came from, but there's this perspective that we live in groups, in all kinds of personal groups, professional groups, faith-based groups, social groups, support groups. And so, I mean, this goes back tens of thousands of years in how we survived 30,000 years ago, 20,000 years ago, by learning how to work together as groups for survival purposes. So we hope that, my goal has been to create the best group possible, regardless of who's in the room. And we'll talk a little bit about that. So we wrote this book. I'd done a fair amount of lectures. Jerry and I had both, and we'd published a couple of papers by 2016. The editor of Safer Society Press approached me and said, "Do you want to write a book?" And I thought, well, I think there's enough material to write a book. And so Jerry and I worked on that for a while before we finally got it published. But the subheading, the subtitle, engaging the full potential of the group experience, we had to argue for that, because that really is what this is about. The book's full of ideas and techniques and theory and some things that everybody learned in graduate school and then applying it to our field. But I think as I've done training over the last decade, that's really what this is about, is how to get the full potential to be evolving and to help our clients experience that full potential in the group. That's what this is about. One thing we've learned from the literature and in practice, interaction between members, it has been maybe the mantra of trainings that we've done and written about. It's not just group therapist center of the room. We'll talk about that a little bit more, but engaging the group with each other, helping them develop connectedness, which is the roots of cohesion, which is the most widely studied therapeutic factor. Helping that occur, even though our treatment is rather structured, and we'll talk more about what treatment looks like in a few minutes. When I talk to clinicians, part of the education is when I work with the group to help the group do the work, when the group is doing the work together, that my job is easier. My job can be more about facilitating their work between them. And as I learn to let go of the burden of feeling like I need to be the center of the room and trust the group to engage and do the kind of work that we think is the most helpful to them and they think is most helpful, then stepping aside and observing and facilitating becomes much more enjoyable. In our field, there's a huge burden to take responsibility. We'll talk more about that as we go along. So who is this population? This is a unique, most but not all have been convicted of some kind of sexual crime in their jurisdiction, and with Canada, anywhere, United States, Europe, pretty much international. Some of the themes, and that this doesn't represent all of them, but many of them are socially isolated, have lived lives of some kind of secrecy, have few significant intimate relationships, and therefore limited trust in significant others. Often there's impaired self-esteem, and either before they committed their sexual crime or as a result of significant amounts of shame, which is often a powerful barrier. Difficulty with intimacy, which is often a factor if you dissect a cycle or pattern of what someone goes through, their thoughts, behaviors, and emotions before they commit a sexual crime or after. There's often difficulty in relationships, most often some kind of relational difficulty. I used to say that a sexual crime is a symptom of relationship failure or relationship problems. And finally, they all come to treatment saying, I'm the only one that had these thoughts about assault, about children, about some kind of sexually abusive behavior. I'm the only one that's done this. And so they come to treatment very wounded, having lost a lot. I mean, income, career, sometimes family, friends. And so they really come to treatment with a lot of very real human needs. So they are adults and adolescents, men, women, many more men than women. Last time I looked, there were 70 or 80 women in prison and more than 2,000 men in prison, and that's just a fraction of the representation. So it's true, there's so many more men than women, and not too many adolescent girls that I'm aware of. Again, mostly boys, but full range of ages, teenagers to men in their 80s, racially mixed, different faith backgrounds, range of socioeconomic status, and it's international. It's not unique to the United States, although in some cases we've seen some research that the United States has more of a problem than some other countries, and there's some theories about that, unfortunately. So a range of people, a range of situations, and a range of behaviors. Let me just pause there a second. The behaviors, window peeping, which is called voyeurism and DSM, exhibitionism, public genital exposing, all kinds of different situations about that. Adult female sexual assault, either of a known person or a stranger assault. A child molestation with someone they know, with a stranger, family member, interfamilial abuse. The most recent and very much more common recently is men looking at child sexual images on the internet and then distributing them, and in the worst case scenarios, just producing child sexual materials. We try not to use child pornography. So a whole range of behaviors that get prosecuted in different jurisdictions, and most often either sent to prison and receive treatment in prison, or then get court ordered to treatment in the community while they're on probation. So one of the myths is that treatment doesn't work. That there's a misquoted quote from many years ago. A well-known person in the field made a statement. The judge took that statement, and that's been the myth. And the truth is that there's now research that compares treatment, no treatment in different scenarios, and treatment does reduce the incidence of reoffending. We use statistics to figure out if someone's higher risk or less risk based on history, and there's some evidence that those at higher risk with a more severe history do reoffend at higher rates than those that are lower risk. And in the reality, the research says most of these people are lower risk. And so the last study I saw, overall, maybe 10% known reoffense, which is not what we hear. I do some public speaking, and I say, what percent of people get convicted of a sex crime reoffend? Well, people say 50, 90%. That's not even true for the high risk people who've had treatment. So maybe we say 10% reoffend. And we do have some research more recently that says that if they've been through some kind of structured treatment, that there is a less occurrence of reoffending. Now, to be careful, there's a lot of factors that go into reoffending. What happened when they were incarcerated, the whole process of being prosecuted, their life experience after being caught, convicted, prosecuted, and then on probation, being observed on probation for 2 or 3 or 5 or 10 or 20 years, and how that affects reoffending. So there's a lot of variables, not just treatment, that come to play when we think about reoffending. I think the last thing I want to say is, in the research world, we say that reoffending is the only measure that matters. And what we see as clinicians and what I watch in groups is what kind of changes somebody makes while they're in treatment. And this is what has kept me in this field for 40 years. People make significant changes, period. That's the starting point when I do public training. People change. And that's the other myth. So I want to say people change, and there's a lot of ways to think about what positive changes happen in life long before we can statistically measure the criminal justice system and known reoffending. Okay.
Before you go on, there's a question in the chat.
Yeah.
So the 10% statistic is for people who have gone through treatment, or is that the recidivism rate regardless?
That's the ones that statistics comes from a study that is comparing treatment and no treatment. So it's those who went through treatment. There's a couple really large meta-analyses in the last 5 years, but that's treatment. So I think I'm going to switch to Jerry in a minute. So when someone gets prosecuted, comes to treatment, they've been through the court system, they've been assessed sometimes by a psychologist, they're court-ordered treatment, and they're on probation, or they're coming out of prison after their conviction. So most often they're in outpatient treatment programs that are run by community treatment providers. There's group and individual outpatient structured programs. There's group-based inpatient programs. Some correctional settings, prisons, have group-based treatment. In rare cases, it's in a psychiatric hospital. And sometimes locally there's faith-based programs. If we say cognitive behavioral, behavior modification, I think for me, I've been doing a lot of psychodynamic work, not psychoanalytic, but psychodynamic within a structured treatment program. Also thinking about family systems. Some programs include family members in the treatment. There's also 12-step groups, self-help groups that a number of people end up in, not as their primary source of treatment, but as support. SAA and SA and SAA are often helpful. The last thing before I think Jerry's going to take over, the last thing I want to say is I mentioned the range of behaviors. We see people that meet criteria for DSM, criteria for voyeurism, exhibitionism, other paraphilias, pedophilia. Not all clients meet the core criteria for those particular diagnoses, but we do see those diagnoses. And many clients come to treatment with comorbid disorders, chemical abuse, substance abuse, mood disorders, very common, personality disorders, common, not as common, and some other more serious mental illness. So this is a really complex population that we're trying to address as many of those issues as we can, and certainly looking at the risk factors for reoffending. Okay, I think one of the issues as Jerry takes over is many of them have issues with attachment, and that's part of the issue of their being isolated and having difficulty in relationships. So Jerry's going to talk about that.
Yeah, it's funny, but the gentleman named Liam Marshall came up with a theory of where he took attachment theory and applied it to the field of sex offenders. And his theory has really generated a lot of research, and it's kind of a good way, even though it's over 20 years old, it's a good way to kind of look at a way to at least find a way to get our hands around this very diverse group of individuals. So the theory is that that they often have very poor caretaking and negative parental experiences, and that those aversive childhood experiences impair their ability to really form trusting and secure relationships with their caregivers or with anyone really. And that's the beginning of what's often called the insecure attachment style. So you get that bad start, and that impairs their self-confidence, their ability to get along with their peers, their ability to trust in others as older children and as adolescents. So again, you see that further harming their ability to really develop the skills and the self-esteem and the social connectedness to really engage in developmentally appropriate relationships. Sort of earlier on when Steve talked about how, the commonality of this isolation and lives of secrecy, you see that already forming in their disconnection and struggle to really get close to other people. So you move on from adolescence into adulthood. You've got individuals who they lack real experience and the skills and the values to seek and establish, really effective and intimate relationships with other people. Not just romantic ones, but just, with authority figures, with parents, with younger, older folks, everything. So you end up with the individual becoming increasingly isolated, lonely, and that sets the stage for sexual aggression, inappropriate behavior, sexually deviant arousal, and sexually abusive behavior. So we can move on from there. Steve.
Yep. Hung up again. Keep going. Keep going.
So interesting. In our book, one of our chapters is devoted to this theory, and is there research to really support that they have insecure attachment issues. So we kind of looked, we reviewed a lot of the literature, and we found that, is it true they have higher rates of insecure attachment? and we thought the research support was pretty moderate. Higher rates of loneliness, very strong indicator. More socially isolated, greater intimacy deficits and fears of intimacy. Again, very strong support for those. One that was very weak was the idea that they're less socially competent. So it's not that they don't have the social skills, it's that deeper distrust and inability to get close to people in an appropriate way without sexualizing the relationship as with a child or that sort of thing. Aversive childhood, very strong evidence for that. Looked at father relationships and mother relationships, especially they seem to have more lousy relationships with their fathers, which again is sort of the whole notion of toxic masculinity. And I guess that reminds me that as Steve indicated, we're talking about men. These are, or at least are young men or adolescent males. And the group therapy treatment is with male peers. And that's going to be, that's a very important thing to keep in mind. You might have, you often have female therapists and co-therapists, but the clients are men and they have male to male issues that are really significant and play a role in their sexual abusive tendencies. Poor relationships with mothers, but especially with the men, and that makes a lot of sense, really. Next slide. So group therapy with this population. We did a review of all the papers that had ever been written about this topic, going back to like the late 1958 or whatever. And the review at that time, this was 2016, was over 100 articles, 48 of them being empirical, and most of them, the majority being sort of clinically oriented. And if you go to the next slide, Steve, this shows you how the amount of publications on this very topic, the dramatic increase. So you got the 60s, 70s, I mean, that would, but in the 2000s, there's this major leap from what, maybe 25 articles to almost 60 articles. And that rose again in the 2010s. And even in the time since we completed the review in 2016, there's been the interest and the amount of research on this topic continues to really grow. And I think that's a real positive thing because the whole field has moved from in the 90s to being very focused on sort of a, educational cognitive behavioral training sort of model to realizing that, wow, its therapeutic factors make a huge difference in whether the treatment groups are effective. And so, in fact, that's how Steve and I came to know each other. As he had written something on the listserv, and I wrote to him out of the blue saying, "You're on the money there. We have a field of clinicians who don't appreciate the real." What makes groups so powerful. They're great and almost in a very major way, just neglecting the importance of therapeutic climate and cohesion and therapist's qualities of being warm and empathic and supportive. And we, over the 20 years, I think we've had a huge effect in helping the field realize that really good group therapy is use the modality. It's not just a class. It's not just a group of guys thrown together learning some cognitive behavioral principles. It really is about the interactions, the relationships, the learning to be a human with other men. That really is tremendously powerful. So anyway, I guess next slide.
Yeah.
I want you to take this one, Steve.
Yep. I don't know what all of your backgrounds are. We're thinking that you're familiar with the complexity and depth and history of group therapy, the group therapy literature. So just a high level summary, there's been dozens of studies and hundreds of papers looking at it related to group therapy, different disorders, mood disorders, panic, phobia, group therapy with personality disorders, mental illness. And before, when we started looking at this, there were some papers in the general, actually Irv Yalom wrote about treatment of people who sexually offended, did that many years ago. So a variety of disorders, variety of settings where group therapy has been studied. In one case, there's a meta-analysis 2018, 20 of 111 studies were related to correctional or forensic situations. So a variety of settings have been studied. Group therapy has been studied in those. Different types of studies have been published: random control, uncontrolled, comparative. Different types of groups have been studied. Degree of structure has been studied. In other words, highly structured groups, group process, or highly structured group format, or client-driven, much more process. Different theoretical orientations have been studied. Sample size has ranged from 12 to over 600. Number of sessions have been studied. So a lot, group therapy, the general group therapy literature is rich with different kinds of studies over decades. One of the most prominent I've come across is Dr. Gary Burlingame at Brigham Young University in Utah has done a number of meta-analyses and done some really wonderful writing about in the book Psychotherapy Relationships That Work. He and co-authors did a chapter about group therapy and cohesion, and came up with a really nice kind of, here's what the research supports in terms of principles for running groups. A little sidebar, we can come back to that if you have questions. So we're just a high level quick look. There's just a general therapy literature continually demonstrates the efficacy of group therapy, and that goes back decades. A number of meta-analyses, and I don't even have the most recent one here, find that, for example, 72% of group therapy recipients were better off than 70% of untreated controls. Another analysis, significant correlation between cohesion and outcome. And that's really the theme we're going to stick with. Cohesion in the therapeutic environment of the group is a potent source of change, is independent of theoretical orientation. That, if we just hold on to that idea, so when we're training in our field, we sometimes oversimplistically say, if all you do is facilitate connection between group members, which is the roots of cohesion, if you do that every session on a consistent basis, all of your clients will benefit. And that's separate from the curriculums and assignments and all the things that clinicians give clients to work on. There's this factor in groups, and this has really been our mantra. If we help the group create a functioning, working, connected group, they will all benefit. And that sounds simple, and I think sometimes we make it more complicated than it is. And sometimes there's some very difficult groups. I don't mean to minimize that, but there's the key point there. And that's really, as we train in our specialty on helping clinicians in structured treatment programs facilitate their treatment groups, that's one of the focus. I want to stop a second. We are way ahead of schedule already. So please ask questions. We really would enjoy it. We're used to doing in-person sessions of dialogue and conversation. So please jump in with questions, because we're going through our slides faster than we planned.
Elizabeth had some comments in the chat. Elizabeth, I want to invite you. Do you want to say it out loud, or you want me to read it? Okay, I'll read it. What Elizabeth wrote was, lots of people have insecure attachment styles and they are not sex offenders. In fact, I would guess the vast majority with this style are not sex offenders. So she's not sure how attachment style is directly related and felt similarly about loneliness, isolation, aversive childhoods. So just to maybe go back to that, and David sort of seconded, he felt similarly. So
Good point. Good point. Jerry, you want to talk about the attachment piece? I'll go back to those slides.
Yeah, I guess the idea was to try to find a way that could both explain why some men are sexually attracted to children and why other men are aggressively, attacking women. He was trying to come up with one theory that could explain why you had all these diverse types of, sexually abusive and deviant behavior. And you're absolutely right about, insecure attachment is a common thing. But he was trying to say, can this help us somehow explain why these folks go down the sexually abusive road? And I think it's sort of, I'm glad you got this slide up. If you look at the third bullet, it's that notion that, so unlike another person who might have insecure attachment, this person, when they become isolated and lonely, they sort of, they, they, they've, I don't know, they unfortunately find their way down into, these deviant roads. That's badly explained. Let's see.
well, so just to go along with that, so I know that there's been a lot of conversation about incels and people sort of like finding community online that is particularly patriarchal or misogynistic or aggressive. And I'm wondering if you think that like is something that contributes to people finding their way down that type of road.
Well, go ahead, Steve.
Let me take this is a really good question. Well, I think one way to think about it, we have in our field in the last 20 years, the idea of risk factors. And risk factors can be grouped into pure history, like if you had any prior legal behavior, if you had any prior criminal offense, if the person you abused was a male, there's 10 items in a historical assessment that put people in risk categories. Separately, there's another category of risk factors called dynamic or changing risk factors, and those can change over time. And what we think about is it's not any one of these issues, it's an accumulation. So they might have had an abusive childhood experience, parents divorced, they might have been victims of abuse. There may have been other traumatic experiences in their life. They may have been in a situation where they moved all the time and never made close friends. And maybe the father was abusive and over controlling. I mean, there's an accumulation of factors that get someone to turn to sexually abusive behavior. It's not any one of these. It's an accumulation of a number of life problems, failures of parenting, mental health problems, denial about their own sexuality. So we think it's not any one of these, it's an accumulation of many factors. And so studies in our field try to look at kind of in retrospective, say who had attachment problems, who had childhood abuse experiences, who had substance abuse problems, who had witnessed a crime in their family, who had a history of criminal behavior. And so we're saying there's an accumulation of life and personality and personal experiences, and that sexual abuse is kind of the end of that pathway. Does that help? Yeah.
Elizabeth, that was just a tremendously good question. I still feel like I'm a little bit stumped in trying how to explain it. I think what we're saying is the insecure attachment thing is very common in this population. and increases their likelihood to end up in this area of offending. For instance, when the insecure attachment research with sexual abusers, like they found that rapists tended to be what they call the dismissive type. That would be ones who are kind of keep their distance from other people. They're you know, they're distrustful, a little bit hostile, and that child offenders tended to be more what they call the anxious, preoccupied type, meaning they had a lot of low self-esteem. They're seeking connection because they felt so badly about themselves, that sort of thing. But it's not a hard and fast line. But again, it was trying to find a way to understand what, you know, why do folks with insecure attachment go down the sexual abuse road? It's so complicated. It's really hard to explain it, I think. Yeah.
Well, I think we both said it in different ways. It's not just insecure attachment. It's insecure attachment plus a number of life circumstances and personality traits, and maybe the environment they lived in, or other young people they met. So it's a combination of traits. It's certainly not just one. So okay.
Dung, did you have a question or a comment?
Not a question. I want to kind of pick on Dr. Jennings just to talk about. I want to point out that many of those research there, I don't think, you know, when you attach insecurity attachments involved, I don't think you can use any experimental design. I think most of them are cross-sectional design. And most they're showing, more likely they're showing association. That doesn't necessarily mean this a mechanism. Even though using cross-sectional design, you can still kind of infer, you know, mediation analysis, those type of things, but they're not the pure experimental design to have a very strong internal validity to show this is the cause. So this is very complicated. Of course, there are many insecure attachment. They're not sexual abusers, and just like but research show insecure attachment has been associated with many, you know, negative, adverse psychological outcome, and sexual abuse included. But there's a lot of factors. I just want to add a little bit more here. Oh, thank you.
We're not saying it's causal in any way.
Yeah. Mm-hmm.
Good point.
I wanted to ask a question.
Yeah.
What sorts of personality disorders do these offenders suffer from generally?
What sorts of personality disorders?
Yes.
So again, to go back to the idea of levels of risk, higher risk versus lower risk. What we see is people that are higher risk tend to have other criminal histories, and so it brings into play antisocial personality disorder is very common in that part of the population. There's some are obsessive compulsive, not too often dependent. And like psychopathy is not a personality disorder, but again, at higher risk population, psychopathy as measured by the PCLR is more common. It's not the most common, but it's more common. But antisocial personality disorder is probably the most common. There are some that end up in the inpatient treatment programs or civil commitment that have borderline personality traits or borderline personality disorder. That's more common in the incarcerated population than the community-based population. Those are probably the most common. Okay, great questions. Please keep those coming. We'll keep going ahead here a little bit. So we talked about the general group therapy literature, and what I've taken, and this partly comes from the paper that Dr. Burlingame did in the book Psychotherapy Relationships That Work. And I think that was a mid-2000s edition. There's a newer edition. But basically it says if there's good, clear group structure, and there's some parameters about what structure means, what are expectations, what are the nuts and bolts of starting and ending, things like that. and there's a real emotional climate and connectedness. So emotional climate is one of the things that could be measured in some of the group measures, and there's member-to-member interaction. In other words, it's not a didactic group leader presents and group talks to the group leader and everything funnels through the group leader. There's member-to-member interaction, and really that's the roots of cohesion. So all of that, if all of that's present, cohesion is present, all of that is correlated to positive patient change. If I could summarize what I take from the literature in the general group therapy literature and in our field, there it is. And cohesion, as I said earlier, the most commonly researched therapeutic factor that Yalom initially identified, and is consistently positively correlated with positive change. So there's the takeaway. If we can develop a cohesive emotional environment that's safe and with structure, everyone will benefit regardless of what they bring to the group as their treatment goals.
Steve, I have a question,
Please.
if I can. When it comes to eating disorders, we have to be very careful who we put together in a group, because they will sort of like feed off of each other's, it's not the right phrase, but you know what I mean? And so I'm wondering, is that true in you all's experience where it comes to, group therapy with those who sexually abuse, in terms of, do you find that, because it seems like it's very powerful, but do you ever feel like there are ways in which it may not be helpful to have certain folks together, I guess?
That's a great question. It gets debated every now and then. So I can comment two ways. Most programs don't have the luxury of very flexible group placement. Some programs don't have very many group options. Other programs, logistics and other issues, they just don't have a huge range of choices of where they place clients, whether that's institution or community-based. So I've worked with outpatient programs and institutional programs where there's a dozen or 10 or 12 group options. There still might not be a huge range of choices. So to your point, we used to say, well, you can't put a rapist in a group with excuse me for doing all the labels. These are shortcuts. You can't put someone who has sexually assaulted an adult female stranger in group with someone who molested a child, because the guy who assaulted a stranger has often personality disorder traits, sometimes psychopathy, and they're going to be domineering and be victimizing the more insecure and socially passive guy with the diagnosis of pedophilia. And that's just one example. So what my experience has been in two different outpatient programs, we always mixed offense types. Regardless, we would place people based on the clinician's capacity, and there's some research about this. We place people in groups based on the clinician's ability to work with that person, and the goal, excuse me, back in the book, that the chapter about cohesion in groups, having a mixture of traits is often, heterogeneous mixture is often better, and that depends on what traits we're talking about. So we might be careful about placing too many people with high degrees of antisocial traits in the same group. We might try to mix those up more. We want people in groups that have the ability to communicate and interact, as opposed to being very socially isolated and introvert and very difficult to communicate with. But at the end of the day, what always struck me was, once you get past the surface, certainly the offense they were convicted of, and maybe a few other surface traits, there are so many commonalities underneath that run really deep in all these different people and groups. Once we get past the surface, there's a lot of interacting and relating on their histories, on their relationship histories, on their feelings of depression or anxiety or shame or insecurity, all the other problems that came together to put them in a position to commit a sex crime. That's what they relate to in the group. So the group gets down into the roots of who all these people are and what got them in the situation they're in. There's less trouble having different traits, different personality types, different offense histories. There's less problem with that once you get down into the dirt of what brought them there.
Yeah, I think to get back to Aziza's original question, like she was thinking of eating disorders, are you going to get one kid who's getting bad ideas from another kid by being put in the same group? And there has been concern in juvenile treatment of in this area where, you know, you really got to be careful about mixing a high risk individual with a lower risk individual. But for the most part, as long as they're not grossly different in risk level, you do want a certain amount of heterogeneity in the group. And it's so the fear is if you're a real low risk person who's had very little, your crime is relatively minor and you've only gone, have a very little offense history, are you going to be really upset to be put in the same group with someone who's had multiple serious, sexually aggressive convictions? For the most part, that won't happen because they're, if you're the lower risk folks you're going to find those more in outpatient settings. They may have been, and or they're on parole and they're out of prison by that point. So I think that's one way to look at that.
I'm going to move us along a little bit. So back to what happens in treatment in our field. Most programs use some kind of group format. There's a range of types of groups. Not all. There's been some studies done that some programs only have clients in group. Group is the only format. Other programs have individual treatment and group treatment. In a larger study, a meta-analysis, 15 out of 68 were group only, 18 out of 68 did individual and group. Some are closed groups, time limited, everybody in the same group at the same time. Others are rolling open-ended groups. So there's a range of situations where treatment occurs. What hasn't been studied as clearly is specifically the type of group and what happens in that group is not always consistently defined. So I've been consulted with treatment programs and sat in with different clinicians in different groups. And even though there's an overall program structure and expectations and treatment tasks or assignments, how those groups are facilitated sometimes is significantly different from one clinician to another. And that more in the ground group process has not been that well studied. So we can say group-based programs generate results. There's still a lot of unknowns about exactly how those groups are facilitated. So in our field, the first study about therapeutic climate was 1997. Some folks from the UK. And they used a group environment scale by Moose, which is a really cumbersome tool to use, but it's a really interesting tool. So they found cohesion, when there was cohesion as measured by that scale, there were superior outcomes on measures of less distortion, less denial, and more admission. And admission was then a kind of a positive outcome of treatment. When there was a positive therapeutic climate, expression of emotion, the sense of group responsibility and hope was higher. So there for us was a bit of validation about the importance of what goes on in the group, not just the end of the day recidivism study. Another similar group in 2005, group involvement, commitment to each other, encouragement of emotional expression. Here we go again. Cohesion and emotional climate resulted in positive treatment outcomes for this case, a group of child abusers. So again, here we are in our field. This is what's with this population, finding the value of therapeutic climate. Another interesting one, this kind of parallels some work Jerry's done. We for years said, well, we can't treat people with high degrees of psychopathy. They're just resistant, and that was a decade and a half ago. They found promising evidence that cohesion can be achieved with offenders with high degrees of psychopathy, and that the quality of that cohesion could improve over this program's stages of group. So even with what's been in this field considered the most difficult personality structure of psychopathy, this study found some optimism in groups. Some other studies about specifically about therapeutic processes. This one, another study in 2016, and there's been a few more. So they're saying that the therapeutic process is really part of the key to think about delivery of treatment. It isn't just did we give them the curriculum and did they complete the assignments? It's a very task-focused treatment approach. This, we're talking about engagement of the clients, which is again a measure of cohesion. We want them to finish treatment. There was a study that found that failing treatment was a risk factor for reoffending. And so this whole idea of focusing on therapeutic factors as a core part of how program operates, that's relatively new in our field, which we think is really important, because that whole experience a client has when they're in treatment affects their functioning, affects their attitudes, affects their progress and ability to make changes in their life. And so this is encouraging to us. Jerry, you want to talk about this a little bit?
Yeah, it's interesting. A few years back, we did a study in a civil commitment center in Illinois. So what that means is these are folks who have completed their correctional sentences, but are still deemed so dangerous that they could not be released into the community, and they would be sent to a civil commitment center where they're under a civil commitment until they've undergone enough treatment that they can be deemed safe enough to be released. So in this facility, there was about 550 individuals. The term was SVP, sexually violent predators. That was the legal name. And what they had was a whole group of gentlemen who just weren't making any progress. Either they didn't want to engage in treatment, or they would haphazardly engage in treatment, or they would just be, going through the motions. So they identified a group of 50 sort of unmotivated gentlemen, and we came up with an idea of let's run groups for these folks where the entire focus will be upon letting them have a positive experience, interpersonal experience in a group setting with their peers. So it wasn't going to be focused on their target offenses, about changing their target behavior. It was really about just give them the opportunity to just be with each other and learn how to be social, find value in social engagement. So we started 5 groups simultaneously with 10 fellows in each, and we gave an attachment measure at the very beginning, And then we ran this thing for about 8 months and then had them retake the attachment measure again at the end. And we found there were 3 items where there was a significant difference. And guys that did well, really showed a concern about their fellow group members. And we were just really struck by that. And the men really liked these groups, and almost all of them went on to engage in treatment because they finally had a chance to just be with each other and not have to be, I don't know what, not have to focus on the things they're most ashamed of. Not that they, I mean, ultimately they would talk about the things that really mattered and the things they're ashamed of. But to not put that first really made a difference in their ability to relate to each other and benefit from treatment and actually begin engaging in treatment in a meaningful way. The next study actually was, or if you can go back a minute, Steve.
Oh, I've got the next one here.
Was this it?
No. Right.
Oh, this is psychopathy. No, if you can go back up.
Okay.
So then there was a second study from the same group where we went back and we identified all the gentlemen from that 50 that had a psychopathy checklist score of 30 or more. So 30 is a really high number. Many studies use 25 as sort of a cutoff for what's a person that's high in psychopathy. And so anyway, we went back retroactively. It wasn't part of the initial study, and identify what were the PCLL scores for all these 50 gentlemen, at least as many as we had. And of that 50, there were 10 folks, 10 guys that had PCLL scores of 30 or more. And what we found was the guys high in psychopathy made the most progress, and they showed the most curiosity about group. They're the strange, and not strange, but for years the viewpoint in the field was you can't put guys high in psychopathy in a group because they'll ruin the group. They'll be manipulative, they'll be hostile, they'll be lying, they'll be, they're just going to wreck it for the rest of the guys. And so so when they were treated, it was often put all the psychopaths together in a group. And what they would find is they do terrible for the most part, because there's nobody that has reasonable health in that group. But what we found by accidentally mixing high psychopathy guys in with lower psychopathy guys, that they really did well in group, because they finally had a chance to have the experience of being with more emotionally healthy people, and they were intrigued by it. They didn't have to spend all their time on how to beat the system and how to trick the therapist or all the expectations of a person who's high in psychopathy. It was quite a remarkable finding, I think.
Yeah.
So this kind of summarizes some of the conclusions we came from. That and our thinking was that if psychopathy really is an interpersonal disorder, then shouldn't group therapy be a really good modality for that? So our conclusions were, instead of segregating men who are high in psychopathy into their own groups, and the other thing they do is, not only has the tendency always been to segregate them, but to then focus even more heavily on their offense behavior, which is like the last thing that they want to talk about. So why not mix guys high in psychopathy with guys who are healthier, and give them an authentic chance to experience interpersonal growth? Again, these are the high psychopathy folks are people whose only experience is always in hostility to others. what happens when for the first time they actually don't have to do anything except be part of the group. I think it's a really interesting future in the field. And we found confrontation. This was true. This has been true in a lot of research. For years, the field of sex offender specific treatment was really big on confrontation. And the initial target was, you must immediately admit that you committed this crime or we won't even offer you treatment. So you'd run into this battle of trying to, folks who, at the very earliest stage of treatment were in denial of their offense or minimizing their offense, and you're demanding. The idea was to demand them to, as quickly as possible, to admit they'd done something wrong. For years, very, very ineffective, and the research has shown, trying to directly confront folks in that way was not only ineffective, it would derail treatment. And fortunately, the field's come a huge way in that regard, where now they assume there'll be denial as a natural process of being, in this situation of coercive treatment. And that, again, positively, once they've had the experience of a positive, cohesive group where they get acceptance and they can, talk more honestly, then the denial goes out the window for most. It's fair, they'll be honest about what their real issues are.
Jerry, there's a question in the chat. Mary, I don't know if you want to ask it. But Mary says she's been advocating for her clients with psychopathy. And a lot of folks are stuck in old ways of thinking. And so she's wondering how to get access to that group therapy intervention and psychopathy chapter.
Oh, okay. If she can send me an email, and I'll send her the whole chapter.
Great.
And it also includes a very thorough review of all the group treatment of psychopathy. And even though the belief for years was, they just do poor in treatment and they do poor in group treatment, because they only were looking specifically at recidivism. When they looked at other variables as to how did their behavior improve, were they more cooperative, did they have better relationships with other people, you could find that group was quite effective with psychopathy. Yeah. So, who was the person who? I'll just write down if she can. I think our email address will be at the end here. Yeah.
It was me. I can send you. Oh, okay. I'll send you an email. I really appreciate that, because I've had to have a couple arguments with some people above me, which is always challenging, trying to argue to be able to give my clients treatment, and that's been sort of disheartening at times. So I really appreciate that.
Great. All right.
Very good. Great. All right. Let's see. We're getting close to back on schedule. So this whole section was about research within the field of group therapy in general, and then specifically in our field. And just to summarize it, the literature, both generically across group therapy and then in our field, there's widespread use and benefits of groups, and the therapeutic factors, especially cohesion, is consistently correlated with positive behavior change, positive progress when cohesion occurs. So our take home from our vantage point has been to facilitate the groups with an eye toward the therapeutic factors emerging, is how I think of it. And I think to Aziz's question earlier, we do have to address individual differences, responsivity issues if they have other personal, mental health, social problems that they have to resolve that may have been wrapped into what happened in their life before they committed their sex offense. We have to address that. And we may need to adjust how we facilitate groups. depending on who's in the group. So we try not to advocate for a generic approach. There's a lot of individual issues that the program has to take into account and address in the course of treating. We used to do 40 years ago, we'd say, this is a behavior problem, we'll do behavior modification, and then we'll just change their behavior. And that sort of worked, but they found in part that behavior modification in its pure sense may have extinguished part of the problem, but it didn't last. And over years, then we started to think about developing relapse prevention, which somewhat mirrored the chemical abuse, chemical treatment programming. And later, one of the advocates of behavior modification came to say, look, this is more complicated. Well, for example, we can't just extinguish a problematic sexual behavior without helping them learn how to be human beings in relationships and how to be sexual human beings in healthy sexual relationships. And so we started to evolve this much more comprehensive models where we have to look at what are the factors that brought them to the point in their lives where they committed a sex offense, whether it's personality traits, environment traits, relationship issues, mental health issues, and address the package, because it's the package, back to the beginning, it's this accumulation of personal and social situation that got them to the point where they committed the sex crime. So we have to kind of look at that whole picture. And that's the individual differences. Okay, so we'll move on. Sometimes there's a debate, why group? Is it just efficient in terms of time and money? And programs, like we said, 90% of programs in North America use a group. And sometimes what happens in that group is talked about. Sometimes it isn't so deeply discussed. We've been saying not all groups are the same. So the programs say we have a group. Well, what happens in that group? Is the group facilitated? Is the group leader more didactic, instructional? All clinicians don't facilitate the groups the same way. And I've learned that sitting in programs, the same program, multiple groups, significant differences in how those groups are facilitated. And so it's a misconception that you have, you do group-based treatment. That's a good thing. Well, maybe, but really, what's the type of group? How's it facilitated? Things like that really matter. And that's not always the same across a program. And we're not generally talking about psychoed groups. There certainly could be a group process and connectedness that happens in a psychoed group, but generally they're just primarily for education. And so we're generally not talking about that when we talk about therapeutic groups or process groups. Some of the challenges, we've already said this a few ways, it's kind of our mantra. There's very little member-to-member facilitation. We use a spokes and wheel picture sometimes, and it's the facilitators at the center, and all the interactions go between the group members and the facilitator. And the first paper we wrote, we talked about, okay, how do we get out of the middle and not be the center of the wheel and help the group talk to each other. Another is a lot of programs don't pay attention to therapeutic factors. They're not paying attention to whether the cohesion evolves or using the therapeutic factor of hope or universality, which is so true for so many. There's also little or no attention paid to group process. So somebody would say, so I would do supervision or consult with a program, and we'd say, well, how did group go? Well, John did this and Bill did that and Jim didn't do his assignment. So here we are talking about individuals. And so we put together a kind of a checklist of what goes on in the group and how to do supervision around the whole group process. Like, what therapeutic factors did you witness today? When I do consult with a program and sit in a group, I listen for what therapeutic factors I can see present in the room. There's little or no attention paid to that. And interestingly also, there's little or no attention paid to facilitating differently at each developmental stage of a group. So obviously it's very different in a newer group or where there's mostly new members. That requires different degree of facilitation, different type of facilitation. And the other really important one, if you have an open-ended group, a rolling group where people are coming and going, every time somebody new starts the group, we have to think about first stage of development and the question of trust. Or a new clinician comes in, we have to think about developmental stage and there's a question of trust. And so that's not often talked about and taken into consideration when we look at what's going on in the group and how's the group doing. So I think those are missed opportunities, where if we shift the lens, so in our world, there's a huge amount of scrutiny on every individual guy. He's on probation, the court's watching, and our job is to get them through treatment. And we have a lot of responsibility. And that's part of why so many clinicians get caught in being so active in the groups. But to be able to step back and say, what happened in the group is different than saying, what did your client in the group do? And so that lens of saying the group is your client when you're the group therapist. And that's a really hard shift for a lot of clinicians to make, because they've got to do case notes on individuals, and they have individual treatment plans and progress reports on individuals. And when they get out of the program, the courts look at the individual. And so to shift the lens and say, when you're a group therapist, the group is your client. And that brings into play these ideas about group development, group process, therapeutic factors. It's a tough shift in such a scrutinized environment. Okay, so in summary, in our world, in our specialty, group is the most widely used treatment modality in North America and in some ways internationally. There is support for the presence of and evolution of therapeutic factors, and cohesion being one of the most widely studied. And that brings into play, is there interaction in the room? Are the group facilitators facilitating the group relationships? That's the roots of evolving therapeutic factors. And also looking at other comorbid conditions like insecure attachment, relationship conflict problems, communication problems, some personality traits, some mood disorders can also be addressed in a cohesive group process. Gosh, we're at the end of the formal slides. We've got a few minutes left. Other questions and comments? Thoughts, reaction? Curious what your reactions are hearing a little bit more about this specialty.
What do you think of pedophilic orientation a priori to actual child molestation? I read something on that, maybe in the DSM, if you want to elucidate on that, you encounter that.
Pedophilic orientation?
Yes.
Yeah. It's different. So to be very clear, by definition, pedophilia is a sexual interest and behavior in essentially prepubescent male or female. Relatively small percentage of people convicted of a child-related crime actually meet criteria for pedophilia. Some do, some don't. And the same is true with this explosion of people getting into the child sexual materials online, and looking at sexually explicit images of children. Not all of them meet the criteria for pedophilia either. I've had a number of men with pedophilia in different groups, and it's absolutely fascinating. There's consistency in terms of they do experience a lifelong attraction. I think we've looked, there's some of the science and brain imaging studies that say there's brain function differences in those with pedophilia. And so we're starting to say we may not be able to eradicate the attraction. And I think most programs quit trying to eradicate it. Now it's how to live with that attraction, how to not put oneself at risk to act on it. But the parallel back to this, all the traits of somebody who commits a sex crime against children, Many of those men are very uncomfortable in adult peer age relationships. They're relating to children is a bit about their own development, and that they're more comfortable with 8, 9, 10-year-old boys than they are adult men. And so there's a bit of a developmental question here that they have to address. There's certainly the issue of relating to and having confidence in peer age relationships with men or women. And then there's what I've seen so clearly is they have to come to terms with they cannot act on that attraction. And for several number of men I've met, there's a grief process they go through. They have to let go of, I have this core innate, deeply rooted attraction to children. I can't act on it. And there's a sense of grief about that has to get worked through also. So when that happens in the form of a group, then they learn to talk to other men, they learn to make contributions in group, they learn to relate to adult men, they learn to talk about this very shame layered attraction they have, and in a functioning group, they're accepted for that. And so all of that happens in a functioning group. So I've seen a lot of success with that, but kind of looking at that whole picture, not just trying to eradicate the behavior. Yeah, good question.
I have a question for both of you all. Steve, you said something earlier, like you corrected yourself when you used the word rapist. You say we try not to use the phrase child porn. So I'm wondering if you could say a little bit more about the shift in labels and what why we do that.
Yeah, I'll go back to the idea of labeling theory. It was sex offenders for years, and then we had rapists and pedophiles and all of that. And it's been quite a few years now where a colleague actually from New Zealand did a lecture at an international conference. And she really basically said, why are we calling them what we don't want them to be? And that it just was a very simple idea to stop calling them sex offenders, because it's labeling. Just like any other label, it simplifies talking about a category of people, but it also narrowly defines. And I started having my clients, when a new guy comes into group, they cannot say, yeah, I'm a sex offender. That's just not a productive label. I committed a sex crime. Absolutely. Things like that. So rapist, pedophile, exhibitionist, it's to me, it certainly has a derogatory element to it, but it's a label, and labels just tend to not be very productive. There's a corrections department, in the probation department, the special unit that supervises all the people with sex crimes. It's the sexual predator unit. It's like, oh my God, what? That's really not what I want to be called if I'm working in a department of corrections. So it really is, and it's also much more humanistic. It's trying to see these people as human beings with a behavior problem.
And it's especially important with adolescents. What you don't want a young person to be defined by the worst thing they ever did for the rest of their life, because they're going to walk around with this horrible label.
So it seems pretty clear that you all feel like group therapy is really effective when it comes to working with folks who sexually abuse. And I'm wondering, as we wrap up, and other folks, if you have questions and comments, please jump in. But what does a clinician who wants to work with this population need to do to expand their capacity to be able to deal with folks who have sexually abused?
I mean, there's many folks who have private practices, richly receive a lot of referrals for like outpatient group, through like probation or parole. They establish a relationship with the local parole officer group, and it's, I mean, hey, it's a shameless plug, but if you really want to know the field quickly, you could read our book right here. It's on the screen. But But in terms of, is it viable for most folks who are working in an outpatient private practice setting? I think the answer is a big yes. There are folks that specialize more in this, but it's, is that fair to say, Steve?
I would take a little different approach. I would say our international conference is actually next week. It happens every year. Association for the Treatment and Prevention of Sexual Abuse, ATSA, has a national website. On our conference is next week in Texas, and attend that kind of. There's a lot of specialty training, and I would say if somebody wants to get into this field, you need to go to the specialty training and learn the specialty, because it is a specialty. Have a whole range of understanding about sexuality. Have an understanding of these are difficult things to talk about. The complexity and gravity of sexual abuse, it's ugly at times. And so having the capacity to hear those stories and understand those dynamics, I think that's critical. Because in some ways, I need to be a good clinician first to be this specialist. And so being a good clinician, having a good therapeutic history and background, and then learning the specialty on top of that, it's attainable. But it is a specialty. There's some unique things to understand, and there is training all over the country, off and on all year long. So, yeah.
So I want to invite any other questions or comments. We have just a few minutes, and this is the moment.
So in essence, what you're saying is that superego or conscience can be instilled in a person who's a psychopath, a sociopath, antisocial personality, through the psychotherapeutic processes in groups via cohesion, etc.
Ooh. You want to answer that one, Jerry?
Your microphone is a little choppy. I'm not sure.
I'm sorry.
Quite, but I think you're saying, can folks make deep personality change? Is that what you're asking?
Okay.
Yeah. Well, like getting back to the psychopathy group that I talked about earlier, the guys that were really high in psychopathy had never had a chance to just, quote, develop friendships and experience a friendship, and it had profound behavioral effect on them. Is that deep personality change? I mean, it's certainly sets them gave them an experience that makes them curious about, what's healthy relating about. I guess another point is often folks are in both individual and group therapy at the same time. So you have a chance as a clinician to also work with the guys with deeper issues on a one-on-one basis. But we can't emphasize enough how powerful it is for these guys to experience acceptance, to be able to come out of the shadows of a life of secrecy and silence and find that, wow, I'm not alone in dealing with this thing that even I'm ashamed of, and that I don't want to act on this anymore. I want to be a good person.
They feel no shame or remorse.
Yeah.
I don't have an answer to your question. I'm not sure I'm going to say we could insert a superego. I think that's a great question. I think we ought to wrestle with that more. I do think we are aimed at behavior change, which is not the same, obviously, and maybe a higher degree of social connectedness. But I'm not sure about that depth of personality change. Maybe.
Last one, Elizabeth, did you want to say something?
I just had a question about, my sense is that as you're describing what you're doing in your group, it seems fairly generic, like what most group therapists are doing in most process groups. And yet I'm imagining that there's a specific part of it that's related to your population. And I'm not sure that I'm completely getting a full grasp of what that specific difference is relative to the more generic kinds of things that most folks do in a process group. So I was just wondering if you could say a little more about that.
Yeah. And yes, pretty much every program has a very a written down treatment, not curriculum, but a group of assignments that they have to work through and present in a group. Or those assignments sometimes have tasks like examining their family of origin or detailing the pattern of thoughts and behaviors and feelings that led up to their offense. Assignments like that. Every program has something like that. And they often have phases of treatment. So there's a very robust treatment structure that the clients have to participate in and work through this, I don't want to call it curriculum, but this very structured group of tasks and assignments they have to work through and talk about in the group. That's very different than just a classic process group. There's a lot of structure. So what we're trying to do is open up that a little bit to do more spontaneous, more processing work in the kind of on top of the foundation of significant, like a dozen or 2 dozen treatment assignments they have to work through in the course of their treatments. It's a lot of that kind of structure that's very different. That makes sense? Yeah.
So just given that we're actually a little bit over time, for those attending live, I invite you to use the reaction buttons or unmute so our presenters can experience our applause and appreciation. And on behalf of Division 49, thank you for attending this live or watching this recording. And I will be sending out 2 links. One is for assessment if you happen to be interested in CE credit, and the other is for evaluation. We'd love any feedback you have for our presenters, and we'll share it with them. So thank you both so much, Jerry and Steve. This has been really informative. I really appreciate it.
Thank you.
Very much. Enjoyed
Thanks,
it.
everybody.
Okay, everyone have a great day.
Bye.